We know that in cells that are proliferating very quickly, so including cancer cells, single-strand DNA breaks are very common. When that happens, these breaks are often repaired by the PARP enzyme, and the cells can continue their replication process. If we block PARP, that repair cannot happen. So in blocking that, these single-strand breaks then lead to double-strand breaks, which ultimately is leading to cell apoptosis.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Danielle Roman, Manager of Clinical Pharmacy Services at Allegheny Health Network Cancer Institute in Pittsburgh, Pennsylvania, about PARP inhibitors. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks so much for joining us again today, Danielle.
Hi, Jamie. Thanks for having me.
So to start, let's get a brief overview of the history of PARP inhibitors in the field of oncology.
We'll start with what they are. PARP stands for poly-ADP ribose polymerase. So PARP inhibitors are blocking the PARP enzyme. The first indications here were ovarian cancer, and we have since had a number of other indications join the list. So they are now used in breast cancer, prostate cancer, and pancreatic. But I will still say probably the majority of the use currently is still in the ovarian cancer setting. Just a call out here, they can be used as monotherapy, and that is often the case. But there is also some data in using them in combination with targeted agents such as immunotherapy, bevacizumab, or in some cases, hormonal therapies.
So let's dive a little bit deeper into the mechanism of action, because I think it's kind of interesting, very unique. Let's talk about how do they work? How do they actually do what they do?
So we mentioned that there is an enzyme called PARP. So these drugs are blocking that enzyme. We know that in cells that are proliferating very quickly, so including cancer cells, single-strand DNA breaks are very common. So the cells are just replicating so fast that these single-strand breaks happen frequently. When that happens, these breaks are often repaired by the PARP enzyme, and the cells can continue their replication process. If we block PARP, so blocking that enzyme that's repairing the DNA single-strand breaks, that repair cannot happen. So in blocking that, these single-strand breaks then lead to double-strand breaks, which ultimately is leading to cell apoptosis. So we're sort of relying in the mechanism here, we're relying on the fact that we know these single-strand breaks are frequently occurring in DNA, and we're using that in combination with this impairing the enzyme that does these repairs to cause lethality to the cells.
Thanks for that. I mean, again, I think this is very interesting and not exactly really similar to most other mechanisms that we've talked about in other drug classes of how we're trying to prevent the body from doing what it's trying to do to be helpful, but we're trying to eliminate that specifically in cancer cells. And so I just think that's a really unique way that this drug functions.
I agree. It's pretty fascinating.
So let's talk a little bit about the biomarker testing. What type of testing should a nurse anticipate needing to be performed before somebody would potentially be eligible for a PARP inhibitor?
So I think this is a little bit of a tough question. The most common answer here would be patients that have a BRCA1/2 mutation are those that are eligible for a PARP inhibitor. But I will say it is very dependent on the indication, dependent on the reason why we're using the PARP inhibitor. There are some occasions where we don't need to have a BRCA1/2 mutation, but we still have efficacy of the drug. And there are other indications that we must show a patient does have a germline or somatic BRCA1/2 mutation. So that is the most common mutation to look for, although I do kind of direct you back to the specific indications to see whether or not it's a requirement to use PARP inhibitors for that particular reason.
That's a really important point of all of these episodes that we talk about drug class series. The package insert is that source of truth, and will provide lots of details that we can't necessarily cover in these episodes, but good to know that the BRCA testing is something that might be nurses might see that as part of this drug prescription and looking for that for the patients that it's an indication that's required. Let's talk a little bit about the specific agents that are in this PARP inhibitor drug class. Can you give us some names, examples, and again, maybe reinforce their indications or what types of diseases they're used for?
We have 4 agents in the PARP inhibitor class. We have olaparib, niraparib, rucaparib, and talazoparib. So they're all ending with that parparib at the end, which helps us to pick out the ones that are within this class. So as a brief kind of comparison of indications here, niraparib is only approved in ovarian cancer, so you're only likely to see it in that setting. Rucaparib, which I would say in my experience is not as used as frequently as some of these others, but can be used in ovarian, pancreatic, and prostate cancer. Talazoparib, I would say, also is one that we don't use quite as much as the others. And indications here are more limited. So this is the one that we don't see used in ovarian cancer. We see it used in breast or prostate cancer. So those hormonally driven cancers. And then olaparib is the one that carries the most indications. And you are seeing this drug across all of these disease states I've mentioned. So ovarian cancer, pancreatic, prostate, and breast cancer. So really the most data with this agent. And you can also sometimes see these in combination. So in prostate cancer, for example, you may see them used in combination with hormonal therapies. And then both niraparib and olaparib have some data in using them in combination with bevacizumab for ovarian cancer.
Thank you for that. My experience has been that as these drugs have come out and as they become more widely used, additional clinical trials have continued to find out, when is the right time to use these drugs within, the treatment trajectory. Is it as a maintenance therapy, or now we're moving it closer now to frontline or even just an earlier line of therapy? So is there any consistency with that across these agents, or does it just depend on the disease site?
Say highly dependent on the disease site, although I will say you're definitely correct that it's sort of followed the trajectory of in most of these disease states where we see it initially being used as a very late line therapy, but we certainly have seen it move up in settings. So good examples of that would be ovarian cancer, where we are now using it primarily in the maintenance setting after patients have had a response to their platinum doublet chemotherapy. And another good example is breast cancer, where we were only using it originally in the metastatic setting for those patients with a germline BRCA1/2 mutation. But now we have some great data in using it in the early stage, so using it in the adjuvant setting for those patients with a BRCA1/2 mutation. So it's great to see it move up in lines of therapy and have seen some overall survival benefits with that as well.
Let's move into toxicities. What types of typical side effects, adverse events do we see with PARP inhibitors? And are there any unique features for individual agents versus something that's consistent across all drugs in this class?
So I'd say consistent with other targeted therapies, there are certainly side effects to talk about here. And so we will go through those. But I will say as a starting point here that they are generally well-tolerated agents. The big toxicities here to watch for are primarily hematologic toxicities. So it is one of those targeted therapies that does affect blood cell counts. So I'd say the blood cell count that is most commonly affected here is the hemoglobin. So anemia, a very frequent complication that we see, probably a little bit more with olaparib compared with other drugs, but we see it as a class side effect. And we can also see neutropenia and thrombocytopenia with these agents, probably a little bit more niraparib versus the others, but again, can see it across all of these drugs. So that is a predominant one to watch for. Another big one is fatigue. So that is something that we can see with all of these agents. And then I would say kind of the next big one here is nausea and vomiting. So these agents are considered to be moderate to high emetic risk, according to NCCN, for all of these drugs except for talazoparib, which is the one we say we are only using in breast cancer and prostate cancer. And that agent is considered a low risk, a low emetic risk by NCCN. Additionally, I would say just side effects that may not occur with the same frequency of the ones we just listed, but diarrhea and constipation are things that we can see with these drugs. There is a risk of alopecia that can occur. And then as a call out with niraparib, there is some data and monitoring parameters around hypertension. So this is something that typically happens within the first several months of therapy. May need to closely monitor patients that have pre-existing cardiac dysfunction, including those with pre-existing hypertension. I have not seen this in practice, but I've heard from some of my colleagues that niraparib does carry some risk of insomnia. So that is something that we are seeing in practice. And then the last adverse effect, a very important one, but I leave it for the end here because it is a rare complication, is the development of MDS or secondary AML. So this is, again, a rare complication, but there have been fatal cases of this. The typical onset is generally months to years. Probably more common is in terms of years of therapy, and patients can develop this. And seems to be a little bit more common in patients that have had prior chemotherapy with a platinum-based regimen, which is going to be many or most of your ovarian cancer patients, or potentially those treated with other DNA damaging agents. So that could be other forms of chemotherapy and also could include radiation.
All very important to know. And as you said, even though it's rare, just something that our patients still need to be made aware of, and reassuring them that we continue to monitor for both during their treatment and for some time after that treatment. So in terms of managing these side effects or these adverse events, are there any pharmacologic strategies that are routinely used to either prevent or manage any of these toxicities?
I'd say our pharmacologic strategies here are really nothing that's unique, but if we keep in mind our typical side effect profile, in thinking about those hematologic toxicities, I would say there's not much that we can do from a pharmacologic strategy, potentially use of ESA, erythropoietin stimulating agents could be considered in those patients with anemia, but really we need to look at the intent of therapy. So we're certainly going to avoid those in patients with curative intent, and also kind of just dependent on the overall patient status, their risk for cardiovascular issues, and whether we would use that ESA class. And then other strategies, we talked about nausea and vomiting as a fairly common adverse effect here. So antiemetics are going to be a really important part of your supportive care strategy. We want to make sure that all patients receiving these agents have an antiemetic at home for administration. These agents do fall into the NCCN category of not requiring that primary prophylaxis. So patients don't necessarily have to take an antiemetic prior to taking each dose of this medication, but we certainly want to make sure patients have them on hand. So it would be reasonable to just have that antiemetic available as PRN when initiating these agents. But if you have a patient that you're particularly concerned based maybe on their history of having significant nausea and vomiting with treatment, or if the patient is expressing a lot of concerns about that side effect, it's also very reasonable to initiate that prophylactic antiemetic. So having them take something to prevent nausea and vomiting 30 to 60 minutes prior to each dose of the medication. And then just one last call out here, we talked about these drugs potentially causing some GI disturbances, so diarrhea or constipation. So using pharmacologic strategies, so for diarrhea, making sure the patient has a PRN loperamide, and then constipation, we're going to be looking at other over-the-counter strategies, so our laxative class or stool softener class to help with that. And then certainly the non-pharmacologic, so talking to patients about increasing hydration and dietary changes to help with that.
And as you said, most of these side effects are not completely unique or are unfamiliar for nurses. So important just to keep in mind how we routinely treat those. And I really appreciate your comments about having that PRN available for anti-nausea for patients. We know patients, it's the most feared side effect I think most patients come into treatment with, and knowing that we have the ability to do a pretty good job, I think, for most people of controlling it, preventing it in some cases. And so just talking with your patient, understanding kind of what their history is and making sure that we have the right medications on board to support them through this therapy is just a great recommendation. So we know that PARP inhibitors are all oral medications, the whole class of oral drugs. So what administration considerations should nurses keep in mind when they're caring for patients that are on these PARP inhibitors and taking on that responsibility of dosing themselves at home?
I think one of the important things here to consider is the frequency of dosing, and it does vary within this class. So we have olaparib and rucaparib that are twice daily dosing. And then we have our other two PARPs, our niraparib and talazoparib, that are once daily dosing. So those are going to be some important considerations. We want patients to be consistent in the time of day that they take these agents. So choosing, what time of day works for them and trying to be consistent with that moving forward. You could consider administering at bedtime, as we talk about the once daily agents in particular, to reduce the risk of nausea and vomiting. So if you have a patient that's really struggling with that side effect, sometimes changing to a bedtime administration can be helpful to minimize that. But I will, as I mentioned, we've seen some insomnia with niraparib. And so in that particular agent, if patient is experiencing that side effect, potentially morning administration may be helpful for the patient there. A couple other things to mention, these agents can be administered with or without food. So we have some flexibility with that and how they want to take that. But again, consistency really matters. So we ask patients to be consistent in how time of day, but also in whether they take it with or without food. If you have a patient that's struggling with nausea and vomiting, administering with food, even if it's a small snack, may be helpful to decrease nausea and vomiting. And then remember that we may want to add on that prophylactic antiemetic pre-med to time 30 to 60 minutes before the dose if the patient is struggling with nausea and vomiting. I think one other call out here is particularly with olaparib, we do want to avoid grapefruit juice with this agent because of some of the risk with the CYP450 enzyme issues.
Well, you've certainly shared a lot of great information for nurses to keep in mind as they are caring for and counseling their patients as they continue on this drug. As you mentioned, it's sometimes not daily or even, multiple times a day that they're taking this drug, and it can be for an extended period of time. So keeping all these administration considerations in mind is certainly very important for nurses. Moving on to that sort of counseling with patients, what are some of the primary patient education points that you think are important for whether it's pharmacists, nurses, communicating and talking with our patients and their caregivers? What should we be emphasizing when we're educating them about their PARP inhibitors?
I think a main thing here is that we need careful monitoring of the patient's complete blood count and differential. So this can vary with agents, but particularly as patients start these agents, we want to make sure that patients are getting scheduled and following through with that laboratory monitoring parameter so that we can monitor for these potential cytopenias. And then we mentioned that rare risk of MDS and AML. This isn't something, a particularly scary thing to talk to patients about. So because of the rarity that we see this, it isn't something that we need to overemphasize, but I think careful monitoring of blood counts and stressing the importance of that and early intervention here is very important. Certainly the nausea and vomiting risk is another thing to discuss with patients and ensuring that they know how to take an antiemetic, that they have that on hand as they begin these agents. Talking to them about the fatigue risk is another important one, and that they're reporting back if this is significantly affecting their quality of life. This is something that we may need to consider dose reductions in that setting so we get that right balance of being able to continue the medication and giving a patient hopefully good quality of life as they're taking it. Niraparib does carry that risk for hypertension, so it does have a particular call out in the prescribing information for monitoring blood pressure. That is something that would be done more frequently as the patient initiates the medication. And once we see that the patient is not experiencing that side effect, we can certainly back off on the frequency. So usually weekly as they initiate for those first couple of months, and then can possibly transition really to once monthly beyond that.
That is very important. And as you earlier mentioned, we don't often see the impact to blood counts with these oral therapies. And so this certainly is unique and important for nurses to keep that in mind and emphasizing the importance of that as they counsel their patients as they're about to start this therapy. I also appreciate just the comments of that open communication with patients and in making sure that they don't withhold if it's truly impacting their quality of life. And I know some patients, I think they try to minimize that and try to just kind of muster through it and just deal with what side effects they're having. But we know that these many oral therapies are flat dosing. And so there might be some customization of that dose that patients need to find the right dose that is that balance of efficacy and tolerability. And we just have to continue to emphasize to our patients that we can't, especially when they're at home, we don't know how they're feeling unless they tell us. And so keeping those communication lines open, I think, is a really important point and creates a really important role for both nurses and pharmacists as we work with our patients. And kind of moving into that, how do you see nurses and pharmacists collaborating together, working with patients to help them manage their adverse events, help identify toxicities, provide any patient education? How do we serve as that combined team of trusted information and a resource?
I think what you said is really important, that this is a collaborative effort. And because of the home administration here, these patients do need to be followed very closely. So we are not laying eyes on them, usually with the frequency that we do when we have patients actually coming into our infusion centers for treatment. So making sure that there is a plan for regular follow-up with these patients to ensure that they're getting that lab work done, that's being looked at closely, that we're adjusting the dose if we need to based on that lab work, that we are managing the patient's fatigue. Again, that potentially dose reductions may be needed if patients are having that extreme fatigue. And then some of those GI toxicities, I think that, early identification with that is really important for patients being able to remain on therapy. I think a couple other points here in collaboration is initiation of this. So we may be giving these agents as maintenance therapies after the patients have received a previous course of chemotherapy. And remember, these agents have significant hematologic toxicities to watch for. So we want to make sure that we don't initiate this maintenance therapy at a time that the patient's counts are still low from their previous chemo. So we want to wait until they've had hematologic recovery from their prior chemo before initiating maintenance with a PARP inhibitor. As always, talking to patients about missed doses is important. We obviously don't want our patients to be missing doses, but we know it's something that can happen. We ask that patients are reporting that back to us so that we know. And counseling here that if a patient does miss a dose, or even if they have vomited a dose, the recommendation with the PARP inhibitor class is not to administer another dose at that time. It's really to consider that to be a missed dose and to administer the next dose at the scheduled time. So an important point as we talk to patients. And I think one other way that we can closely work together is knowing that there are a couple of these agents that require dose modification based on organ function. So good examples of that would be watching for renal function with olaparib and talazoparib, and then watching hepatic function with niraparib. So that can be something we work together to help identify changes in labs and whether or not we need to make changes in doses based on that.
All great points. And certainly every clinic setup is different in terms of the way staffing is set up and clinical pharmacists embedded in the clinic versus pharmacy access and support. So depending on what site, what type of setting a nurse works in, we don't always have a pharmacist right at our side, but knowing where those resources are, where we can find our pharmacy colleagues to establish these relationships and to be able to work together, not only for PARP inhibitors, but really all medications that we're giving our patients, really is not only a benefit to nurses, but also to our patients. So important to keep those relationships strong so that at the end of the day, the patient is who benefits from that. So all great points. Danielle, what do you think the future looks like for these agents and their role in the landscape of cancer care?
I think we are just continuing to get more information about where these PARP inhibitors have activity. So I think that we will continue to see that as we move forward and hopefully better understanding where they may play a role in other disease states outside of the ones that we've mentioned today. Another area is having more information about how we may be able to combine these PARP inhibitor classes with other agents. So I think we're unlikely to see a lot of combinations with chemotherapy and just that additive cytotoxicity that would be of concern. But I think we're likely to see more information about how to best use them with some other targeted agents, immunotherapy, again, with hormonal therapies and better understanding that. And I would say the last thing here is that we said MDS and AML is a rare risk, but we are still seeing some of this risk present itself in newer clinical trials. So I think just better understanding or better investigation of the safety profile here and better understanding the MDS and AML risk that exists is something that I hope we will see in the future.
Well, Danielle, thank you so much for joining us again on the podcast and sharing your information and your knowledge about PARP inhibitors. Again, a unique drug class, one of many drug classes as we've covered in this series, but it's, I think, really interesting. And I'm glad we've spent some time focusing on it specifically just to help nurses become better aware of how this drug class is unique. As we reach the end of our episode, we always like to run through a series of some quick fire questions just to help summarize some of the great topics and points that we've made today. So to start that off, how do you think healthcare professionals should evaluate any hidden bias that they might hold when it comes to PARP inhibitors?
So I think we can have a tendency to sometimes think these oral agents don't carry the same kind of risks as we see with traditional chemotherapy. And that's a little bit different here. So we've talked about those hematologic toxicities being something that's prominent and that we need to watch for. And I think sometimes we also can look at our patients and particular patients and have some concerns about their adherence, maybe affordability of some of these oral agents as they're going through specialty pharmacies and prescription drug plans. But there really isn't an exact IV equivalent here. So I think kind of understanding that while education is extremely important, in particular for those patients where you may have some concerns, that sometimes this is the right therapy for patients, and we need to kind of give them a shot on these oral therapies before kind of ruling it out as an option.
What are some of the common misconceptions about PARP inhibitors?
I think one of those could be that they're only effective in patients that have that BRCA1/2 mutation. And again, remember here that there is some data in particular disease states that we can use them and that they work in the absence of those mutations.
What's something about this topic that's not often discussed, but you wish people knew more about?
So I think it is something that comes up in discussion, but really, I think emphasizing the fatigue risk here and the fact that it can be very limiting to patients. These may be patients that are still trying to work, that are raising families. So we could be using them in our younger patients. And patients often, as we talk about using this, say, in the adjuvant setting for breast cancer, we're doing this for a year. In maintenance for PARP inhibitors, we are doing this for several years. So really keeping patients on these therapies is very important. So that may require dose adjustments to maintain that. So I think keeping that in mind is a really important point.
What additional training or education do you think oncology nurses need to stay current in this topic?
I definitely recommend the oralchemoedsheets.com, that partnership between ONS, HOPA, ACCC, and NCODA. I think these are great resources. They have sheets built out for all of these PARP inhibitors. I am regularly using these sheets in my practice. They also have them in Spanish. So it's really great to have that option for patients.
And what are some additional resources that you would recommend maybe for patients or other providers who want to learn more?
From provider standpoint, a couple of things here would be, I feel like the NCCN ovarian cancer guideline has a nice table summarizing the use of these agents in ovarian cancer, which we said is really the most common indication to use them. And there are some complexities here in using them in first-line maintenance versus in patients that are getting their second rounds of platinum doublets and using them that second maintenance course. So a lot of complexity there. So I find that table to be very helpful. Again, that's in the NCCN ovarian cancer guideline. And then I would say from the patient standpoint, just truly those oralchemoedsheets.com is a great place for patient resources. And then the PI does have some patient language as well that could be used for education.
Well, Danielle, thank you again for joining us today on the podcast. It's a great summary, an interesting drug class. And I really appreciate your time and your expertise that you shared with us today. Do you have any final comments to share with our listeners?
Yeah, I would just emphasize that, despite all the toxicities we talked about, these are generally agents that we can keep patients on that tend to be fairly well tolerated, but particularly those cytopenias and fatigue can be limiting here. So remembering that dose reductions may be necessary to keep patients on therapy is a big point.
Wonderful. Well, thank you so much again.
Thanks, Jamie.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.